Good afternoon, everyone, and thanks for joining us in this sixth, I think, or fifth in the series of webinars that we've been hosting monthly. Today, we're going to talk about an important topic, which is the potential impact of national standardized set of episode definitions. And my name is Francois DeBrant, and I'm the Senior Vice President of Commercial Business Development at Remedy Partners. I'd like to cover a few housekeeping topics before we dive in. First, you're going to have the opportunity to submit questions during the webinar. To do so, please make sure to type them in the question box on the GoToWebinar panel, and we will do our best to answer all of them at the end. Second, we are recording this webinar, and a link to the recording will be emailed as soon as it is available. Finally, at the end of the webinar, a link to the recording will be emailed as soon as it is available. And finally, we will be prompted to complete a brief survey. This survey is important because we're going to ask specific questions about your feelings relative to a standard set of episode definitions. And we want to make sure that your voices are heard and your opinions are recorded. So today we've got two speakers joining us. One, Dr. Frank Opelka from the American College of Surgeons, and the other one, Ray Hirschman, who is Vice President of Population Health Accountable Care Strategy at Cerner. So let me start off with first setting a little bit of the stage, and then I will pass it to Dr. Opelka for his perspective on why this is such an important issue for physicians, and then we'll pass it to Ray so that he can give the industry perspective. So let me set the stage. As you know, in this country, there is no standard set of episode definitions, which means that everyone and anyone can define an episode of care in whatever which way they choose. And there are, in fact, a large number of organizations that have defined episodes of care. If you think about the largest episode of care payment program in the country, the Bundle Payment for Care Improvement Advanced that CMS is running, it has defined episodes of care for that program, which are unique to that program. Then if you think about other initiatives that may be going on in states like Arkansas, Tennessee, or Ohio, where the Medicaid program has initiated episode of care based incentives and payments, each one of those states has its own set of published episode definitions, and the list goes on. So what are the practical implications of this heterogeneity in episode definitions? Well, it leads to, instead of favoring pricing transparency, it leads to a cacophony of prices that are never comparable from either one site to another within a specific state or for prices within a specific state. And on this slide, what I'm showing are prices for the state of Maryland for the average cost of a vaginal delivery, which on the state's official site, wherethecost.org, is the average is $11,590 with a range of $10,000 to roughly $15,000, depending on the provider. Right below that, you'll see an excerpt of the Fair Health site. Fair Health is a national organization based in New York, and it pegs the average cost of a vaginal delivery in the state of Maryland at about $8,000 if you're in network and $15,000 if you're out of network. Guru, which is a initiative from the Healthcare Cost Institute, and HCCI has data from a number of commercial plans, including Humana, United Healthcare, and Aetna. It pegs the average in Maryland at $13,600 compared to the national average of $12,772. And finally, Healthcare Blue Book, which is also has prices for a variety of procedures across the country, pegs the average at about 10,000 from a low of 5 to a high of 15. In other words, not only are the averages different, but the ranges are different, and the comparisons are inadequate because everyone uses a different definition. So which price is right? Well, your guess is just about as good as my guess, and that's the problem. Then when we think about another practical implication of episode definitions that can vary, think about programs that use or rely on episodic care definitions as a mechanism to pay providers and to institute, in some cases, downside financial risk. So Optum has a maternity program which has been published or talked about in a number of national publications. I believe there was a write-up in the Wall Street Journal recently. And in that particular program, it includes pregnancy and delivery and newborn costs through the 30 days postpartum. And in that program, in some cases, hospital can become bankers and funding the episode until it's over for a certain period of time. How long? Well, that depends on the definition that you use. There's another nationally recognized program that was talked about, in fact, yesterday in the Wall Street Journal, the Pacific Business Group on Health's Employers Centers of Excellence Network, that has a different definition of an episode. In their case, it's because these are national centers of excellence, it's roughly wheels up or wheels down to wheels up. In other words, when a Walmart employee is shipped to Virginia Mason in Seattle for back surgery, the entire time during which the patient is in Seattle at Virginia Mason for care is covered under the episode of care. Nothing before, nothing after. So that's another definition of an episode. Cigna has recently released a prospective bundle, and the episodes are defined as all costs included during the inpatient stay, both facility and professional services, but it's only from admit through discharge. Aetna has a prospective bundle, which includes post-acute care and some leakage. Anthem has an episodic care payment model, which is retrospective, but also includes pre, peri, and post. In other words, depending on the payer with whom you're contracting, both the episode definition, the time window around the episode, the inclusions and exclusions are going to vary. That makes it hard for everyone. It makes it hard for the consumer to understand what their financial liability might be. And as importantly, it makes it really hard for physicians or hospitals to manage the heterogeneity of all of those programs. And to delve in that particular aspect a little bit more, I'm now going to pass it on to Dr. Opelka from the American College of Surgeons to talk a little bit about the physician's perspective. Frank?
Francois, thank you, and thank you to Remedy for hosting this today. It's really a privilege for us to get to try and highlight some of the challenges we see with this, and I think you've kicked it off by giving us a great perspective. Next slide. So when we think about this, we know where we're going with all this cost information. We know we're going to end up in value, and value will become an important part of how physicians deliver services and what's involved. So we look at all these cost perspectives, not in isolation, but as part of building quality of care. And it's how do I put a team together that's looking at building upon putting all the services I need for a patient into a journey so that we can then efficiently build the quality, efficiently build the cost, take out the unwarranted care, and so forth. And if I have 3, 4, 5, 6 different ways of doing that, it becomes increasingly difficult to figure out who you're going to bring into what meeting for what purpose to really build what is the value proposition. Next slide. So Francois alluded to this in that there's a structure to these episodes, and we look at this and say, well, there's a structure to the clinical care models that even though no one place has the exact same clinical care model, there tends to be an overall framework upon which we could build all of these episodes. Well, we're seeing that with each vendor building the same episode differently. And how do we bring the clinical community together to provide that input if They're actually building the triggers differently. They're looking at different time windows. They're assigning different services for inclusion or exclusion. Each vendor can come up with their own argument as to, and out of good rational sense, as to why this one gets included or excluded. But we look at this and say these should be clinical builds for clinical services, and then figure out how to wrap those relevant services around into an episode that has commonality to it. We also see that as ultimately this will help the patients as we shift risk to the patient. They've got more copays, they've got more deductibles, they want to price shop. So if they've got multiple different ways of representing this in their own market, how can they actually even come to understand what the episode is that they're pricing? Next slide. So the way we look at this construct in general format, there's a clinical model that has relevant services in it. That's where specialty medicine has really started to come together and start to say we could build these relevant services in clinical care models and put them into a standard episode data definition file that everyone could use. At the same time, there's grouper logic. There's a series of overlapping rules, concurrent services, risk adjustment. Those actually could also then be applied to those clinical episode definitions. So we see the specialty society as giving you step one, and then the grouper logic giving you step two. So we look at this as another important aspect of it is that the episodes have to be standard and complete. If you narrow these episodes down, you're not going to catch the variation. So standardized episodes may actually be easy to put together, but if they actually are not the same full episode of clinical care, you can't build a team around it, you can't value it, put it into the value proposition. Incomplete or partial episodes exclude services and will misvalue or underprice the overall service, which then ends up misinforming the team and misinforming the patients. So we're looking to have no limits on these. They need to map the clinical care to the business logic together so that we can actually address what's warranted variation and what's unwarranted variation. You can actually see that there could be variation that a tertiary care center would require more services for a given condition that aren't available in other services. We can make those adjustments appropriate for the kinds of care needed from a primary service to a tertiary care service. There are all sorts of ways to make those adjustments, but beginning with a standard allows you to make those adjustments. When you have multiple different systems coming at you, it becomes increasingly difficult to manage the warranted variation. Next slide. So this is just a classic representation of what comes at delivery systems in the bundle. And here's a bundled service that's going to apply logic to all the different services that are included. And you can imagine getting 4, 5, 6 different reports like this. That becomes very confusing to the delivery system trying to build efficiencies in the model if everyone has different elements that are included in SNF or included in the rehab or included in the admission and so forth and so on. You've got to have consistency in this so that on the delivery system side where you're looking for the efficiencies, we can actually build in the clinical logic that maps to the payment logic that's in the episode. Next slide. So for us, it really comes down to episodes that are being constructed on a consistent trigger with a common time window with relevant and plausible services that the teams can embrace the episode clinically to seek high reliability and delivery of quality and efficient care. That the patients can understand this and engage in their care and understand this from the point of even price transparency, that you can apply quality metrics across an entire common episode rather than have to chop up the quality metrics as well. Having constant or consistent business logic within the risk corridors also helps the team accept the actual concept of the episode, and the performance indicators would be meaningful and actionable both from a business side and from a clinical side. Thanks so much, Francois. We really appreciate the opportunity to contribute.
Well, Frank,
Before we move to the industry perspective, I wanted to go back to this slide and just have you delineate a few things for me, because you went over, I think, the most important concept as we talk about the potential for standardization of episodes, as well as the effects of heterogeneity and differences. So here, as I understand this slide, Frank, we're looking at the net effect of the actual costs over some target for an episode, and the green represents the episodes in which the costs came underneath the target, and the red, the episodes for which the costs exceeded the target price. And then underneath there is the delineation of the different types of services. In blue, the index admission, and then a smattering of home health agency in yellow, and we see readmissions and SNFs and IP rehab, all kinds of things that are driving costs more towards the right tail of the distribution. So if I understand the premise here, let's assume that you had a different definition. Obviously, the impact could either be you have more gains, or the impact could be you have more losses. Or explain a little bit why standardization ends up by being important.
Sure. So imagine this is 200 patients in one institution that may have one hospital, or maybe even has 3 or 4 hospitals. And all these procedures are coming at them being differently represented as to what's included in the index admission, the professional components, the readmissions. These all make up the development of the actual cost curve. And if each particular procedure has 3 or 4 or 5 different ways of representing that same procedure to that one institution, what we're actually getting is problems with reliability. The signal to noise ratio starts going up on the noise, and which one actually has the actual real price, which one has the one where we're actually beating the price, and the other one where we're exceeding the targets. Where do we actually find that it maps to the clinical common sense and the trust? So you could look at all the different services. They could all be represented differently by all the different methodologies. And it just creates noise on the clinical side for where do I sit down with the team and attack the problem? It becomes unbelievably chaotic. And so you just go to your biggest vendor and you only fix that one because that's the most populated group of patients that you have. So standardizing this allows you to actually make this improvement across all payers in all markets and benefit all the patients.
And I guess there's another, of course, legitimately, when people talk about standardization, who gets to do that? And we'll get into that a little further. But just staying on this picture for a second, if I'm risk averse and I have the ability to define what that episode would be, it seems to me that simply excluding anything that happens post-acute is going to solve a big risk problem for me if this is a surgical episode, because seemingly much of the variation is coming from stuff that happens once the patient leaves the surgical suite. So that may work well for some physicians. However, that defeats the purpose for most employers and purchasers who are really interested in making sure that the care of the patient extends to post-surgery and that there's these warranty periods, et cetera. So there's a natural tension, but also very clear and important financial implications. So what are your thoughts on that?
So I look at that, if I understand you correctly, when both sides have this knowledge and it's common to everybody that's involved, you could actually take those patients who are always beating the target price, if you will, and make that your book of business. But then as a consumer, you could turn the knob down and say, well, we're not actually going to have that same target price for these that are low end. And we're going to encourage those who are on the high end and who could actually remove and reduce the complications, improve the quality, and remove the unnecessary, unwarranted care, and so that the payer purchaser group can actually align incentives using a standardized approach, because it makes sense to both parties as to where you need to put the right alignment, whether it's clinical improvement or whether it's in how you cost or price and incentivize the model.
And I think what you're saying is, and you said it earlier, an episode definition that doesn't include anything that's in the red here kind of defeats the purpose, right? At least for those who are paying the bills in American healthcare. Great, thank you. Ray, the industry perspective.
All right. Thank you. And Francois, thanks again for having us, and for Remedy for putting this on. I think before I jump in, one of the things that's exciting about this time, I've been working with Francois and others on this conundrum for going on 30 years. And I've been fortunate enough to sit in different seats as a delivery system, working with individual docs from the consumer perspective, representing large employers, large health plans, state sponsors, a bunch of different lenses. And today I'm going to mainly speak from a provider system perspective, but also make sure I kind of touch on those other stakeholders that are part of this equation. And for this, I'm just going to do a bit of a setup at Cerner. Most people kind of attribute Cerner to the EMR clinical workflow side of the equation, but over the last 6-7 years, we've been investing heavily in kind of total population and value-based contracting perspective. What are the implicit requirements to make those value-based contracts plausible, scalable, sustainable? You need data, not just administrative data, but clinical data that's aggregated and normalized and structured. And so we've got this thing that's happening. We're moving where the provider community is really looking at two different types of purchasers in parallel. The first is what I'll kind of refer to as industrial purchasers. They're buying as an 800-pound gorilla, a carrier leveraging their volume as a purchaser with the delivery system, or the TPA that has self-funded business, or it's a coalition of employers, or a big employer, or it's CMS as a sponsor, or the state as a sponsor, and the delivery systems are negotiating and dealing with purchasing from that industrial purchasing perspective, while simultaneously having the individual consumer patient who's doing more of a retail type of purchase at an N of one type of view. And the two are kind of highly interdependent, because when it's the consumer coming in, it's really the consumer using the plan design and the benefit, and therefore underneath it, the reimbursement arrangement that industrial purchaser structures, but then is expecting the consumer to also participate in, and that provider organization has to deal with both of those different purchasers. And so then you layer on top of that, the lack of standardization in episode definitions, and you run into this kind of complexity kill situation where it makes it just way harder than it needs to be for the industry to move forward. And so when we look at over time, our industry is pretty damn good when we set our minds to it. When there's positive response, when the different stakeholders all say, listen, having standards lifts all boats, right? We're pretty damn good at that. We, whether it's EDI standards or HL7 or ICD-10, smart fire interoperability is starting to emerge pretty quickly as another way to create this kind of liquidity and interoperability of applications and data. But over time, you could also point to DRGs, which I think we're on version 37 or 38th iteration of that. Been around for going on 35 years, and we went from kind of basic definitions. We introduced severity adjustment. We introduced hospital acquired complications, and that has evolved again, and it's somewhat of a standard. But purchasers have been also on the employer and kind of at the industry level have also been trying to do standards as well for transparency, Leapfrog, NCQA, STARS. And so with that as a backdrop, if we go to the next slide, I'm gonna click through just this is a very typical delivery system. This could be apply to any kind of common delivery system in the market where they have their own owned and operated providers in the middle there. They have a bunch of different technology. Then they may participate in a shared savings arrangement. They may participate in BPCI. Then they have an affiliated broader network that's also participating in these programs. And then there's a number of different health insurers that are also bringing different products and services around an ACO or a network. That health system also may be working on direct employer contracting or with a coalition of employers. If you click one more, there's also, I think we got one more click there, two more clicks, Francois. But they're still dealing with their foot still on the dock in the old world of fee for service, and there's future acquisitions, and this is typical. This complexity of all these different types of reimbursement models. And so when you take that and then you apply the problem that we have right now of lack of standards in episode definitions, it just compounds this problem for a delivery system. So if you go to the
before actually, yeah, and before we move to the next one, I think importantly linking it back to the prior one, Ray, a lot of the transactions today are facilitated by certain things. So if you think about the MSSP ACO program, it obviously still relies on the fee-for-service system, but you've got standards around CPT codes and diagnosis codes, et cetera. When you have affiliated providers around which you're trying to create a clinically integrated network, a SIN. To your point, there's now the FIRST standards, which help in the interoperability of when you're linking up with Aetna or Cigna or United or the local Blue Plan or even Disney through a third-party administrator. Most of the transactions, whether it's eligibility, benefit design, accumulated, et cetera, is all done through standard messaging and electronic data interchange. So while this picture is complex, there's a lot of standardization that has helped manage this complexity, except when it comes to defining payment models and in particular episodes. Am I capturing that appropriately?
Correct. That's correct. And those where we agreed to EDI standards for eligibility, it was to help everybody, and buyer and seller, in the equation. And so I think we got to have that same mindset as we think about standard definitions for episodes. And so this is a different way to kind of think about it a little bit, but there's inherent risks. Let's go do bundle payment and let's go do that, right? And let's not address those things that we could do if we wanted to that will make this easier, right? Make this more sustainable, scalable, and that's that inherent risk side, the left side, right? So this is kind of where we are today. It's slow. It has a lot of friction. I'll kind of quantify the complexity that Frank and Francois have been talking about before in another minute here. But it does also inhibit innovation because people are just spending so much time just trying to work through kind of this complexity that's avoidable. The residual risk is if we did agree to some standards, it's still going to be hard, but it sure is going to be a heck of a lot better for both buyers and sellers if we agree on the part of the complexity that we could, as an industry, acknowledge, address, and therefore eliminate. And so I think this is still, how do we get to a radically different place 5-8 years from now? One argument is let's kind of deal with the residual risk, the parts you can't eliminate, but let's drive up to and address parts of the complexity that we as an industry could kind of, again, get positive, buy-in on and just move forward in a systematic way. So if you flip to the next slide, there'll be people that argue about how much of the healthcare spend can actually be addressed in a bundle payment arrangement. And Francois and others have been trying to quantify this over over last dozen years or so. But I think the general kind of rule of thumb is that anywhere from 50 to 70% of the healthcare spend, maybe even higher, could be addressed and paid for in a bundle payment context, in that type of model. Significant upside, significant upside. The challenge, I think, that's inhibiting this realizing this potential is some of that complexity that I was speaking to on the prior slide. So let's just do the math. I think for me and for others, I think if you just pencil this out in the most simplistic terms, this is kind of a typical moderate sized metro health system, depicted like in that earlier slide with all the different concentric circles kind of overlapping there. And on the low end, at a minimum, let's say they're just have Medicare, they're just doing BPCIA. And there is a state program, and it's the state that's doing the program, not the different managed care organizations that are doing the contract. So there's just one of those. And then there's the four bigs, right? United, Blue, Cigna, Aetna, and then 4 regional carriers. That's kind of like the minimum level of kind of payers out there that are trying to approach a delivery system to do some form of bundle payment. So say at the low end, you have 10 different payers at a minimum that, and we're only talking about 32 episodes, just as illustrative, at the low end, that if you don't have standard definitions, that delivery system is dealing with at the low end, 320 different episode definitions. And at the higher end, what if there was still BPCIA and 2 MA plans wanted to pursue a bundle payment arrangement? Maybe there's 3 Medicaid MCOs instead of the state being the payer because they pushed it out to MCOs, which is happening in most states. And maybe instead of there only being 4 bigs and 4 regionals, what if there's also what if there's 6 regional carriers competing and maybe some 2 direct contract models with employers through a big employer or through a consortium of employers. So you could get your way towards 18 different contracts. And let's again, there are just only 32 episodes. It means that health system is dealing with 576 different episode definitions. Say we wanted to push this out and say, why don't we get it up to where we're doing 300 episodes, which is on the low end of the potential of what the how far we could go in this. This means the delivery system is dealing with between 3,000 and 5,400 episode definitions just to do their job. So this is like the simple math. This doesn't get into all the different explanation of benefits and payment for the consumer and how it's presented on a website so people can make a decision. I mean, I'm just talking about just the definition of the episodes. And so this is if we had standard definitions, we'd be talking about 32 definitions, not 576 definitions. If we had 300 episodes, we'd be talking about 300 definitions, not 5,400 definitions. And that's just for one health system in one market. Okay, so this is just simple math. But if you do the math, I think it's apparent that we could solve this problem if we agree that it's a good thing to pursue a common set of definitions.
And I guess as Frank mentioned earlier, this is a killer. I mean, if you're a clinician leader within a health system, and you've got these variations in what's in and what's out and what's the length and how 5,400 is just a crazy number. How can you standardize care? How can you possibly focus? I mean, is this inherently, and this is great, I actually had never done this math before, Ray, maybe because I was afraid to do it. But is this essentially why we're stalled?
I think this is a big contributor. I could tell you that just in more the global budget type of arrangements that are MSSP or the ACO deals, even those where whether it's Atrium or Banner or whoever it is, when you look at every one of them has different quality measures in those contracts. Everyone has a different way in which they deal with outliers and stop loss and how do you hedge out that tail risk. And so there's a lot of complexity, and those are the easier models because it's on a population-wide basis and it's hard. So then when you get into this, I think I personally believe that this is a headwind that a CFO is looking at, and a chief informatics officer. Everybody's looking at this and saying, wow, I mean, how do we design a business around this? And what you end up doing is you get kind of bogged down in the technology and the implementation, and a lot of the resources go towards what is avoidable friction of trying to implement this. So I'm biased. I think that this is one of the bigger contributing factors. I think it's the Tower of Babel. If there's so much complexity and differences carrier to carrier, the providers kind of throw their hands up and say, well, what do you want me to do? I mean, how am I supposed to run my business? It's hard enough. So to kind of wrap this up, I think, if we had, convention in the market, I think just the administrative complexity from a payer perspective, and this means that what we come up with has to work for TriZetto and all the other benefit administration software vendors, and how do you configure it? How do you implement it? How does it present to the consumer? A lot of complexity there that would get addressed if we had standards. The analog of the benefit administration is the rev cycle side on the provider side. So I think that those are 2 points of friction that could get mitigated. And as we just kind of talked about, if we could knock down the Tower of Babel, this unnecessary variation in definitions, I think we would accelerate the market pretty substantially. I think this next point to me is kind of the next opportunity, and I think it's a big one. I think if you're working in this space down at the ground level, the administrative data has a lot of value. I think we've broken through and said, look, that stuff works, you can use it. But the next wave is to say, how do you integrate the clinical, the EMR data, and really get after the risk stratification aspects of it, the complexity factors, and the level of measurement around quality requires a level of data integration. And again, I think if every definition is different for episodes, and then you want to apply this EMR level of data into it to improve the actual concept of bundle payment, it becomes that much harder because of the additional amount of.
Well, and that actually, yeah, and that.
You have to.
Well, and Frank, I'm gonna ask Frank to interject here also, because one of the points that your first slide, Frank, talked about the value equation, and this really, I think, hits home that point, and I'd like you to comment on it, because how do you define value if the unit around which you're accumulating pricing information, cost information, varies continuously?
The way that Ray has demonstrated here, and it's not making me feel good. It really defaults to, I'm going to look at who my largest payer is and where I can demonstrate value in that sphere, and just tell everyone else, you're going to have to go based on that, because there's too much complexity in here. I'll break my team down. I'll wear my team down trying to figure out each element of quality, each element of cost that goes into each value statement for each individual episode or condition out there. And they're going to take their eye off the patient. That isn't what we want them to do. So this is a really unique representation of how this complexity can get out of control, and it moves away from the patient. This solution needs to move back to the patient, and it needs to standardize a way that we define an episode of care clinically and then price it in the same way. Now there may be variation in how the different vendors choose to put on risk relative to that, but at least give us a baseline.
Yeah, and I'm thinking, Ray, also if I'm an employer, and again, some of this is about transparency, but some of this is also if I'm presented by any one of those multiple scenarios that you gave here, one of the four bigs or the four regionals, if I'm presented with a program that says, or I send out an RFP, right? Because I'm trying to select a payer that's going to help me execute a value-based payment model. Because Catalyst for Payment Reform, I'm a member. They've asked me to do this. I'm trying to figure it out, and I sent out an RFP asking for show me the value proposition on 30 standard procedural episodes. I'm never going to be able to compare the results of that RFP because everyone's using a different way of determining what the price is going to be.
Yeah, and that kind of leveling the playing field, making it apples to apples. I think that's I think in that procurement space when you're that industrial purchaser representing a whole bunch of beneficiaries, and think about that big employer who has people in 5 different cities,
Right.
Where it's not plausible to think that at the beneficiary, at the consumer level, they're going to make sense of it, let alone at an employer who then hires, a consultant and an actuary, and then they have to figure out if the payer and the provider can even administer that benefit in a consistent way. That's hard enough. So I think we could solve some of this, right? We just have to pick off what are the things that you can't. It's residual. There's not a way to eliminate it, but if there are chunks of this that we could target and eliminate, I think we should.
Yeah, and this, thank you, because I think it brings us to at least thinking about a path forward, and we have, and a couple of months ago, the three of us and many others were hosted by Frank, you and your organization, the American College of Surgeons, to talk about a potential path forward. And I think one of the central issues, because again, it goes back to the chart you showed where you had the greens and the reds, and if I'm a provider, I'm thinking, hey, to the extent that I can really tighten the aperture, tighten the definition of the episode, tighten the time window, then I'm going to avoid all that red. But if I'm the employer or the payer, I'm thinking, well, that doesn't make any sense because the ability to improve on total costs of care, the ability to generate better outcomes is if I widen the aperture. I want episodes that include a post-acute phase so that if something happens to the patient, they're going to be able to come back in. I want to move upstream to condition-based episode and the management, putting a bundle together around low back pain as opposed to just catching the patients on the back end of poor back pain management and now having to go through potential surgical treatment. So there's this tension, and I want both of you to speak to that. There's this tension between broad episode definitions, and to an extent, we can look at the CMS bundle payment for care improvement as a very broad episode definition. It's all in, except for a few things. There are also examples of very tightly defined episodes that some of us are familiar with, where you really have very few things except for maybe 5, 6, 7 services that are aggregated together in what is putatively called an episode, doesn't show much variation, ends up by being mostly a unit price comparison. But there is legitimate tension. So number one, as we think of a path forward, what's the starting point? And how do we ensure that the interests of all sides are appropriately represented, right? Frank, you talk about the clinical validation of an episode. Face value is important. You show outputs from a grouper to a physician. If it includes all kinds of junk that are completely irrelevant to, say, the management of coronary artery disease, then it loses face validity. So how do we resolve that tension as we think of that path forward? And, you know, as I put on this slide, this cannot be a side job. Maintaining, you know, 600 plus episodes with new CPT, ICD and HCPCS and other codes coming out every year cannot be a side job. And yet it needs to be balanced. So, you know, Frank, maybe you can start us off with how do we do this?
So there's a couple parts to your question. The first is just maintaining the episode definitions. Clinical care is always changing. It's always evolving. Every year, new widgets come out, new ways of treating things come out. So you've got to keep the episodes fresh. That means at least in some consistent manner, episodes need to be governed and supervised and make sure that all the elements who are participating in that episode are appropriately valued and assigned to that episode. So there's actual governance that needs to happen from a clinical standpoint. But the other part of this is, I mean, this is transformation and changing practice habits and practices and incentives is hard stuff. It's the real science of behavioral economics. So how do I take the transactional world of fee for service and start to broaden it to a full, complete episode? And part of that comes from building out maybe a smaller episode that's narrow, but doesn't have the risk reward, doesn't have the proper payment incentives, to a full risk episode that really allows you to look for warranted and unwarranted services to deliver high quality care for the most optimal resource use. So using the behavioral economics tools, this is where working with the vendor community, the health plan community comes into figuring out how do we get everybody in on taking the full episode with appropriate levels of knowledge to manage the episode, the fiscal tools needed to take on the risk associated with it, and so forth. The delivery systems aren't made to jump from this point to the end point. We're going to have to walk through a logical transition. And having multiple different episodes to do that to only adds a whole nother layer of complexity of which episode am I doing for what risk in what way. So standardizing these episodes first and then developing a common framework for marching through the behavioral economics for taking on the full risk, that all needs to be done in a thoughtful way.
Right, and Ray, you know, we've seen you talked about purchasers coming together, having created the NCQA, having, you know, launched the Leapfrog group to a certain extent, along with CMS, and, you know, Congress has a little hand also in bringing forth the National Quality Forum. There are examples of dedicated organizations, but there are also examples, as you mentioned, the fire standard, where it's not really a dedicated organization, but there is some organization whose job it is to really do this, and it's not a side job.
Yeah, and the idea that we could, you know, crowdsource and make sure it's multi-stakeholder, so that it does what we come up with, you know, it could work totally well and make sense from the provider side, but if on the payer side you can't administer it, it's not going to work. You know, if it just works for the payer and it doesn't make any sense for the provider, there's going to be some tension there. But I think the key here is as we approach this, we have the end in mind and we figure out what those trade-offs are from the different stakeholders, and I just know we could get to consensus on it because we've done it with other problems in this industry. So I think that the other opportunity is that we have huge amounts of data readily available now where we could model and test this and get people to understand that doing pre, peri, post isn't as risky if you understand that the data is going to. A lot of times people are reviewing it from their vantage point and they haven't had access to all the data before, and so their point of view or their perspective is kind of dated, because we can bring that data together and make it readily available today. 5 years ago, that was a pretty big challenge. So we've, just as diagnoses and treatment changes over time, I think our liquidity and availability of the full spectrum of data across the care continuum is way more readily available now, which again de-risks.
And Frank, there is a starting point, and I think it's important for those who are listening to us to understand that doing this from scratch wouldn't make a whole heck of a lot of sense. And fortunately, some of us have worked on a starter set, which is more than a starter set. It's a comprehensive set for Medicare. And so why don't you at least introduce that, and then we can talk a little bit about what it would mean to have a dedicated organization, as the slide says, a true public utility, and what would the governance of such an organization look like?
So we've worked together and along with CMS in the effort that CMS put out in establishing an episode grouper for logic for them to use. And I think it's a very unique grouper that has an ability to develop literally hundreds of different types of condition episodes and over 50 procedural episodes that allow you to lay out in a very standardized way risk-adjusted models for establishing clinical episodes that were developed by the clinical community with a full set of resource use tied to it in a standardized fashion. So we look at that as a great place to start. It's already been exposed in the federal system, but it's not really been leveraged. We've not used it. Some of it has been that we've noted so much variation that has come out that we've almost not known how to deal with that much variation. But I think if we came around and all said, this is the standardized approach, we could begin to figure out how to sort through the complexity and the variation that's out there. And the other thing that Ray's saying is, I think, a really critical point about the data systems now that we have today that we didn't have 5 years ago. If we had a standard set like this that was available for everyone to use as a public utility, then we could build those other informatics support elements tied to that particular standard, rather than asking the informatics world to have to build 5,400 different versions because there's 5,400 different episodes.
Yeah, no, that's an important, very important point, and I'd also like to point out and shout out that this work was masterfully organized and coordinated through Brandeis University with some of the same people who were at the origin of the DRG system, and so I think, and we talked about that as being and having emerged and being a standard, and it is clearly time to move away from simply looking at things on an inpatient, as all of you have said, and moving to a broader view. So we have a starting point, and when we started this effort a while back, Frank, you'll remember that we called it the patient-centered episode system. And so let's talk a little bit about governance, because clearly something like this, and Ray, you mentioned it, you got to have the buy-in of the multiple stakeholders. It has to make sense. There's got to be clinical validity, but there also has to be a basis for financial accountability. So
from my perspective on this, we see that for all the reasons that we've elucidated today, and Ray's piled onto my list with a whole new list of reasons, we think that this ought to be a public utility that is available not just for CMS, but for everybody to use. And how do we actually put that out there as an open source, if you will, that it's freeware that people could use. It needs governance. It needs a board, a public board that has inputs from the patient community, as consumers, from the purchaser community, as the folks who are really underwriting all this, from the vendors who actually implement it, as well as from the technology side. And I've added now a whole new list of technology, listening to Ray, and then our clinical inputs in defining the clinical aspects of the episodes. It also then, once you create this, it isn't something that just maintains itself. It needs ongoing governance and input. It needs basic finance and operations. And given the grand scheme of things, it would not be overbearingly expensive to the community at large to maintain this. I think you'd get a lot of volunteerism, bringing in the different aspects from the delivery system about where the different points are that need adjustments or improvements, and from the clinical community and maintaining their aspects of it. I don't know, Ray, you may have more to add on this.
No, I agree, and there's other models that are emerging that are similar. I think around the quality measurement side, there's new standards in CQL and a way to codify a quality measure and the evidence that is making it easier to crowdsource and have measurement stewards and apply that on a scalable basis. I think we could use that same approach here. There's no question.
Yeah, and look, I think we also all recognize that if the field, meaning the vendor community, the purchaser community, the provider community, and purchasers and payers, if they don't accept this emerging standard because they don't feel that their interests are being represented in what's being done, then it's never going to get adopted, and clearly we're still in the Tower of Babel. So I think just when one stops and really considers what would an organization like this do, what would its scope be to be successful and to sustain itself, it obviously has to have an output that becomes one that's acceptable by multiple parties in the industry. So thank you, both of you, for participating today. I think we do have a path forward. It obviously is going to rely heavily on industry acceptance and support. For those of you who are listening, you're going to get a survey that asks your opinion about the potential benefit of having standard episodes and having something akin to a public utility become the steward and the promoter for those definitions. And so we encourage you again, when you get that survey, please respond to it, because it also helps us as we plan for our further webinars on this topic. So thank you both to Ray and Frank. Thanks for everyone for joining. If you haven't already, please visit our website at remedypartners.com/our events, and you will be able to register for the next webinar in this series, which is Opportunities and Barriers to Steering Patients to High-Value Providers, and that will be held on December 12th. So as a reminder, following this webinar, you will be prompted to complete that survey. We ask that you do that. We value your feedback, and we'll use it to improve what we do going forward. And so thank you, and have a great rest of your day.